Good morning. Today's presentation is on carpal tunnel syndrome. My name is Tom Trumbull. I'm the chief of the Division of Hand Surgery in the Department of Orthopedics and Sports Medicine at the University of Washington. I'd like to present our presentation on techniques for treating carpal tunnel syndrome, which is a very common entity affecting many adults of all ages. Just to take you directly to a surgical shot and kind of focus in on the problem at hand to define carpal tunnel syndrome, the problem for carpal tunnel syndrome that affects people both at work and often at night, waking them up from their sleep, is the compression of the median nerve. The median nerve is one of the key nerves supplying sensation to the hand. And as shown here on this direct image from surgery, that this is the median nerve. This is the more normal color of a white glistening appearance to the nerve. And here you can see the hourglass indentation and almost the bruising as the discolored portion of the nerve. What's happened is this has been a shot at surgery, and I sort of apologize if we've kind of gone directly to the heart of the matter. This is the thickened ligament that's been released in order to expose the nerve. And you can see here that the veins that have been trying to enter the nerve have been compressed and shut off by the tremendous pressure from the carpal tunnel ligament. Once this has been released, it allows reversal of the symptoms. But if the condition continues unchecked, people can develop permanent loss of sensation and permanent weakness and motor function in the hand. The epidemiology of carpal tunnel syndrome is that it has a female predilection. It affects women almost twice as frequently as men. There's no particular association with any one type of occupation. It's been thought for many years that keyboards were associated, but now with many different keyboard designs, we're not able to pinpoint that there's one design feature of keyboards that are related to carpal tunnel syndrome. We do know that there are many factors associated with carpal tunnel syndrome, but I do want to point out for the audience that the overwhelming number of cases occur in healthy patients that have no predisposing factors that we know of. Factors such as diabetes have a significant factor, and for those patients who do know that they take insulin and have their diabetes monitored, the chances of developing carpal tunnel syndrome probably go up to 15 to 20% of this population. The condition can occur in pregnancy and actually frequently responds at the end of pregnancy, and the symptom can actually reverse. And this is probably one of the few true reversals of the condition. It's also been thought to be related to thyroid conditions, particularly low thyroid levels known as hypothyroidism. In patients with inflammatory arthritis, particularly arthritis that's not held in check by medications, the swelling from the arthritis can actually induce carpal tunnel syndrome. Finally, the thing that we know that is the most consistently correlating with carpal tunnel syndrome is increasing age, and the peak incidence occurs at about age 55. The symptom produces numbness, and it's in this area shown by the green. This is the area supplied by the median nerve. It's interesting that the median nerve only supplies half the ring finger, so that in classic cases of carpal tunnel syndrome, people will present to us and say that their thumb, index, and middle finger, and even half their ring finger are numb. However, many patients have a hard time differentiating whether it's the whole hand or only part of the hand, and this is why a good examination and studies are necessary. The symptoms produce nighttime numbness and often pain. The patients frequently tell us that they have to shake their hands and wake it up, and what we find out is what they're doing is they're moving their tendons and they're getting the fluid along the tendons called the synovial fluid to glide and decompress the median nerve. It can often occur with activities that produce wrist flexion for prolonged periods of time. So driving, using a blow dryer, even holding a newspaper can be the kind of activities that will produce these symptoms. The classic physical findings occur with percussion of the nerve, that is tapping it lightly right over the wrist where the nerve is very superficial and where it's being compressed. And this often produces electrical-like signals that are very uncomfortable, that radiate out to the tips of the fingers. The Phalen's test is a test that is done by holding the wrist in a slightly flexed position for about 30 seconds. Not forced, but just in a comfortable position. And the patients should say that they begin to notice that tingling sensation at the tip of their fingers that is so typical of carpal tunnel syndrome. More advanced cases can actually demonstrate sensory loss and even motor weakness, and people with advanced cases will tell us that they're dropping dishes and they cannot hold on to small or thin objects. The best test for carpal tunnel syndrome is an electrodiagnostics study. This has been termed an EMG, which stands for electromyogram, but really it's an electromyogram which samples the muscles and determines whether there's abnormal electrical activity in the muscles. But the most important part is actually the NCV, the nerve conduction velocity. This is the way we pick up moderate and mild cases, because what happens is, like an electrical wire, the nerves conduct electricity. And when the nerves don't have enough energy because the blood supply has been shut off by this pressure from the ligament, they can't conduct at the proper speed. And this causes a dysfunction that is what the patients feel as numbness, and if it continues long enough, can actually produce weakness. So it's this latency or delay period for the conduction across the wrist that is what we use to confirm our clinical diagnosis. The treatment of this is often to wear a brace, and this is so widely known that we'll often see people come into the office and they've been advised by their friends and family to wear this brace, and sure enough they find out that the brace helps to keep them from waking up at night. But if they try to go without the brace for any prolonged period of time, the symptoms come back. Oral medications such as a non-steroidal anti-inflammatory medication that you can get conveniently over the counter can help to some degree, but to get a significant improvement, oftentimes it's necessary to perform an injection with a corticosteroid. This has also been referred to as cortisone, and a small amount is injected. We try to make sure that we use a material that includes the lidocaine, which is a numbing medicine, as well as a steroid that is not irritating to the tissues. This is very important. But unfortunately, these injections don't provide permanent relief of symptoms. And in patients who we've confirmed the diagnosis clinically, and if they have evidence by their electrical studies, essentially all of these patients will require surgery to get the relief that they need from the numbness and pain. Once the electrodiagnostic studies demonstrates a latency or delay of over 4 milliseconds, the condition does not reverse and surgery is indicated. The technique that we like to use is an endoscopic carpal tunnel release. There are several different techniques for this, and this is just showing one device. This uses a special tube that has a fiber optic device in it that allows us to visualize the nerve and the ligament and release it using a small incision at the wrist rather than having to make a large incision across the palm, which was the conventional technique that was referred to as the open carpal tunnel release technique. This particular device is referred to as an AG endoscopic carpal tunnel device. Especially with the endoscopic device, patients recover very quickly after surgery. They find that they can drive immediately after they recover that day of surgery, so the next day they can drive. Writing is usually fairly easy within 1 to 2 weeks. Very prolonged work on a keyboard for someone who has to do transcription or handle heavy workloads may take a month or even more with typing. And then the heaviest form of work may take 2 months for the full recovery. But in general, patients can return to all their activities within 1 to 2 months after the surgery. We wanted to evaluate the effectiveness of different methods for treating carpal tunnel syndrome. And so at the University of Washington, we began a prospective randomized clinical trial that involved multiple centers. And these included the University of Washington, as I've mentioned, as well as the University of California, San Francisco, and also the University of California, San Diego, sort of a West Coast study. And what we wanted to do was to make sure that our study, unlike previous studies, provided a questionnaire directly to the patients, both before and after surgery, so they could tell us, without having members of the surgical team try to translate their results, this allowed the patients to tell us directly how they were feeling, were they getting relief of their symptoms, and were they getting improvement in their functions? Were they able to do more activities after surgery? The other thing we wanted to add to the study was a way to look at the dexterity, because one of the chief complaints is that people told us that they felt a clumsiness. They felt that they were dropping objects and had difficulty doing activities. And these two tests, the Jepson-Taylor and the Purdue pegboard, were added specifically to look at their dexterity. They're interesting tests. They were actually developed to look at disabled children, but as we began to use them more and more, we found that they're just a very effective way to evaluate how quickly you can work with your hands in an accurate way. Well, we enrolled patients from July of 1996 to July of 1999, and this concluded 147 patients. Because the condition is frequently bilateral, that means it can affect both hands, we actually ended up enrolling what we called 182 hands, but of course they were always attached to our patient. At the University of Washington, we enrolled 137. In San Francisco, they enrolled 37 hands, and at San Diego, 19. The diagnosis was made similar to what we've talked about in the beginning of the presentation, with nighttime numbness in all patients. All patients had positive clinical tests, and importantly, all patients had a positive electrodiagnostic studies to confirm the diagnosis. So we made sure that we were treating a condition at each medical center that had met the appropriate diagnostic criteria. Let's break the groups down into two different segments. So the endoscopic group involved 75 patients, or 97 hands. The average age was similar to the overall national average, was 56 years. And you can see the 2-to-1 female to male ratio, 49 female and 26 males. The dominant hand, that's the hand that does the writing and most of your key functional activities, that was involved in 53 of the patients. So you can see a slight weight towards involving the dominant hand. And the duration of symptoms averaged 28 months in this group. In a very similar fashion, the open carpal tunnel group, the numbers were similar. We had 72 patients, or 95 hands. The average age was 56 again. There were 26 female and 26 males. The dominant hand was involved in 53 cases, and the duration of symptoms was slightly longer at 31 months. Well, all patients underwent a very rigorous preoperative assessment, and this included the questionnaires for the symptoms, which is this one, the CTS SSS, and the CTS FSS was the test that was designed to let patients let us know about their functions. And the important thing in these tests is it notes the number of problems that you're having. So if you score higher, you actually have a lower or worse functional result. We also wanted to test the sensation very carefully before and after surgery. The Semmes-Weinstein monofilaments are these very fine nylon fibers. They're like a fishing line, and they get finer and finer as the test is used to measure very accurate sensation. The other test for sensation was the 2-point discrimination, and we'll show you a picture of this a little bit later, where we bring 2 points very close together to see how well you can discriminate between 2 small points on your fingertip. Strength was assessed using both muscle testing, and in particular, the muscle that's affected in carpal tunnel syndrome is the large muscle at the base of the thumb. So what we want to do is we want to apply pressure while someone tries to bring their thumb out of the plane of the hand, and that's called abduction. The muscle that performs this is the abductor pollicis brevis. And so we want to measure the strength of this muscle. We also want to get an overall grip strength using this device called a JMAR dynamometer, and we want to measure the pinch strength. And this is done with a device that can measure both your ability for key pinch to do a thumb to index versus what's called a 3-jaw chuck, measuring the ability of the thumb to come to the index, middle, and fingers. As mentioned earlier, the dexterity was assessed using these Jepson-Taylor and Purdue pegboard tests. The Purdue pegboard test uses the the ability to assemble these small washers and cylinders in the board, and it's a time test. So the more that you can assemble in that time period, the better your results. The Jepson-Taylor looks at how well you can perform in a timed fashion a series of 7 tasks, and these include everything from large objects to small objects, and this is just an example of one of them, which is stacking checkers, and the goal is again to do it in a rapid time sequence as a way for us to measure light small object movement. The study was very rigorous and included measurements at 2 weeks, 1 month, 3 months, 6 months, and 12 months. We wanted to make sure that we went out as far as a year to make sure that we didn't miss cases that either recurred, that is, came back, or if there was a difference in symptoms that between the two techniques that didn't present until fairly late in the game. Again, during this time period, we performed the questionnaires, the sensation testing, the strength testing, and the dexterity testing. This is just showing this 2-point discrimination technique. This device moves these 2 prongs closer and closer together, and a good score is if someone can detect them at about 3 millimeters apart. We also wanted to look at the scar sensitivity, and I'll show you in a second a diagram of this. And what we wanted to do was to measure how much pressure someone could withstand without having discomfort at either just before the wrist, right over the wrist in the carpal tunnel, and in the palm, to see if there was a difference between the techniques. With better healing of the scar, the patients can withstand more pressure without having any discomfort. And finally, this stocking is just meant to show that a stockinette, this light cotton gauze, was applied on the hand so that the person that was making the measurements, which was not the surgeon, would be blinded. That is, they would not know which type of surgery the patient had, so they wouldn't be biased while they were making the measurements. This is just a little cartoon demonstrating the device. A plunger is used to apply pressure up to 6 kilograms in total directly over the wrist and even in the palm. Again, the more pressure that you can withstand without discomfort, it means that the scar is healed more smoothly and in a proper fashion. So the open carpal tunnel technique, which was the one that has really been the standard in the country for many years, was performed using these classic landmarks along the base of the thumb to create an incision about 3 centimeters in length. Unfortunately, this is the same area that most people tell you that in their palm is probably the most sensitive, especially when they try to do any type of gripping activity. The endoscopic technique uses a smaller incision made just at the level of the wrist, as shown here. And this allows us to release the ligament. The other advantage is because you visualize the ligament using a fiber optic device, you can control, so you just release the ligament and none of the other adjacent structures. And here we have a small video clip that I'd like to go to that kind of demonstrates the technique and what we see during surgery. The endoscopic device is a handheld device with a white nosepiece that contains the blade assembly. The gray cable brings in the fiber optic light source. The blade is activated by depressing a trigger mechanism. A small incision is made along the lines of the wrist crease. Care is taken to use the landmarks of the tendons of the wrist in order to avoid injury to small nerve branches that go to the palm of the hand. The end excursion of the release is marked out in the palm. The dissection is carried down to the fascia or plane of tissue overlying the nerve. This is prepared into a flap that can be folded back on itself to make a gateway for entry of the endoscopic device into the carpal tunnel. Here you see the flap is folded backwards and retracted. A small elevator is then used to reflect or move away the tissue from the undersurface of the ligament to improve exposure. Small blunt devices, called dilators, as shown here, are used to prepare a space for insertion of the endoscopic device. The surgeon uses the opposite hand to palpate or feel for the tip of the device as it passes the far point of the carpal tunnel. A line parallel to the ring finger is marked out as the line of insertion of the endoscopic device in order to avoid injury to the median nerve. the device is gently inserted, and the depth of insertion is marked out against a scale that is on the white nose piece of the endoscopic device. Let's go to a different case so that we can use a split screen technique in order to view the hand and the endoscopic view simultaneously. You can see that by applying pressure in the palm, we can find the far end or distal end of the transverse carpal ligament on the endoscopic view. The blade assembly is deployed and the device is withdrawn in order to release a portion of the ligament. The tension of the ligament that's compressing the nerve causes the ligament to dramatically open once a portion has been released. We can now find the last portion at the far end of the ligament that needs to be released. The blade is deployed again so that we can release this. Once this portion is released, the final portion of the ligament is released as the device is withdrawn towards the wrist. You can see that this spares a layer of tissue, including superficial muscle, fascia, and fat, to provide a protective surface over the nerve. We can now deploy the blade assembly once again and withdraw the device to completely release the ligament. Device is reinserted, and you can see that the ligament has dramatically expanded following the release, and one has to actually rotate the device from side to side in order to see both edges of the released ligament. This shows one edge. This shows the intervening tissue that's been spared. And now we rotate the device to show the opposite edge of the ligament. Once the retractors and the device have been removed, the incision is closed using simple sutures. After surgery, no splints are used. We allow patients to begin moving their fingers and their hand immediately after surgery. We allow them to start using their hand for daily activities. At 2 weeks, we remove the sutures and start exercises called six-pack exercises, which again are not meant to measure how much you can carry home from the grocery store, but as a group of exercises that help to improve your hand dexterity and get your fingers back mobile and flexible. And at 4 weeks, we start a gentle strengthening program with some light putty. I would like to show you the data we had from the study, which was fairly convincing, showing improved function with the endoscopic technique. Because the legends vary depending on what type of test we have, it's kind of important to go through each one individually to evaluate the results. This is measuring the questionnaire for carpal tunnel function, and what you see is a higher score means more problems, more difficulties the patients experience. So with the endoscopic technique, you can see that they have a lower score as compared to the open technique as shown in red, where they're showing a higher number of functional problems, particularly in this 2-month period of time. And as you're going to see in the upcoming slides, that it's this 2-month period that's probably the critical window as the difference between the endoscopic technique and the open technique. Now this one uses a reverse scale. This is going to show satisfaction. So you can see that the endoscopic technique shown in pink actually has a higher satisfaction score. These patients were more satisfied as far as their overall activities as compared to the patients in red for the open technique. For scar sensitivity, again, this is measuring the amount of pressure that the patient can withstand without any discomfort. So you can see that the endoscopic technique is now doing much better, and again, it's this critical 2-month window where there's improvement in the function and better healing of the scar tissue. Once we get past this window, the results become very similar late on in the follow-up. Grip strength, again, now showing higher grip strength. They both drop off fairly rapidly in that first 2-week time point, but then very quickly patients begin to regain their strength. At 2 months, they've got nearly 3/4 of their normal grip strength, and finally at 4 months and 5 months, they really have regained as much grip strength as they had before surgery or even more. The sensation improved in both groups of patients, but there was no difference. And again, the critical period for the improvement was this period again of the first 2 to 3 months following the surgery, where we noticed most of the sensory improvement. But we're very pleased to see that this did improve with both techniques. The dexterity testing, as measured by this the Purdue pegboard, shows again during the critical time period that the dexterity recovers faster in the group with the endoscopic surgery. Overall, a key factor was the fact that the patients with the endoscopic group returned to work almost 3 weeks faster than the group with the open carpal tunnel release. And these were groups that were very carefully matched as to the heaviness of the labor that the individuals were performing both before and after surgery. All patients did successfully return to work. In the open carpal tunnel release, there were 2 minor problems. No patients had serious complications that did not resolve with the course of the study. 2 patients in the open group developed a condition called reflex sympathetic dystrophy, known by the abbreviations RSD. And this is one that we always have concerns about in hand surgery. RSD is an increased nerve sensitivity. So these patients present with a great deal of sweating, very sensitive palms, and a very pink or reactive appearance to the hand. Both these patients improved with oral medication and with hand therapy. One patient in the open group required revision surgery. No patients in the endoscopic group required revision surgery, and this one patient did ultimately make a full recovery. So in conclusion, the endoscopic technique is safe and effective for the treatment of carpal tunnel syndrome. The endoscopic technique allows for earlier return to work than the open carpal tunnel release technique. And finally, the endoscopic release allows for early recovery of function, particularly strength and dexterity. In both groups, the sensation improved. Again, the critical window is that first 2 months, which probably explains why the patients were able to return to work, as they had better grip strength and less sensitivity in their hands. Thank you very much.